Well, hi, I'm Dr. Gary Richter. It is a pleasure to be here. I'm a veterinarian in the San Francisco Bay Area in Oakland. I've been working with medical cannabis in my patients for probably the past 7 or 8 years, both medically and sort of on the regulatory legislative side. So I'm really excited to be here today and share some information with you and my two amazing colleagues.
Hi, everyone. It's Trina Hazzah. I'm a veterinary integrative oncologist in the Los Angeles area. I am also really excited to be here with you all and go over some of the, applications of the cannabis plant and some kind of tips that one might need to know when guiding a pet parent and using cannabis. I also have been using cannabis in my patient population for probably about 7 years. And have started actually just recently started a cannabis consulting service called Green Nile Incorporated, where I offer pet parents cannabis consults as they are, in a situation right now that they're very lost and kind of struggling trying to figure out which products to buy and how do they dose and so forth. So it's been really exciting to slowly leave the conventional oncology space or integrative oncology space and really doing mostly cannabis work. And it's not just for cancer, but I'm talking to pet parents that have pets that have multiple different diseases like arthritis and seizures and other things that I'll go into when I present. So thank you so much. And I'm really excited to be here.
Hi, my name is Jeff Pollard. I'm a small animal practitioner in Southern California. I came to the topic a few years ago when I chaired a committee of the California Veterinary Medical Board that developed the cannabis guidelines that we'll talk about tonight. So I am familiar with the regulatory end of things. Quick disclaimer, I am not a lawyer.
All right. Well, Dr. Richter, do you want to get started? And so Dr. Richter's going to go first, and then I'll go, and then Dr. Pollard will present, and then we'll have some time at the end for some questions as well.
Sounds great. Let's get this thing underway here. Okay. So welcome, Cannabis and Veterinary Medicine. I'm going to kick it off tonight talking about the endocannabinoid system, as well as the phytocannabinoids and terpenes that occur naturally in the cannabis plant. As I go through many of these topics, I just want you to just please realize there's a lot of information on some of these slides. I'm really not going to go through all of it. But I did want the information just to be here. So if you went back and looked at the slides later, you would have some more information. But in the limited time we have today, I want to talk about the endocannabinoid system and its components, and then move into the cannabis plant itself so we can talk about how the components of the cannabis plant interact with the endocannabinoid system. So let's start with the endocannabinoid system, also known as the ECS. This is a series of neurotransmitters that was discovered in the 1980s by an Israeli researcher named Raphael Mechoulam. The ECS is an incredibly complex regulatory system. It's found in all animals. It is found throughout the body. This picture you can see right here just gives you an idea of really all of the various interactions that are really just occurring in one cell. So let's really kind of dive in. So when we look at the ECS, there are 3 components. There are the endocannabinoids themselves. These are the neurotransmitters. There are the receptors for the endocannabinoids. And then there's a handful of regulatory enzymes that we'll talk about as well. So of the endocannabinoids, there's really 2 that we just need to talk about. So there's anandamide, which is also referred to very frequently as AEA, and 2-arachidonyl glycerol, also known as 2-AG, certainly much easier to say. One interesting thing to note about these endocannabinoids as neurotransmitters is they are generated on demand. So they're not sitting in a vesicle, inside a nerve at ready to be released across the synapse. They are created as needed. They travel across the synapse, and then they are thus degraded. We'll look at this a little bit more in detail in a moment, but I just really wanted to point that out because I do think it's an interesting fact about endocannabinoids. So the ECS is really all over the body. The CB1 receptors, as you'll see sort of in the lower left-hand corner of the slide, the CB1 receptors are primarily in the in the brain and the central nervous system. The CB2 receptors really are very prominently placed throughout the body. Although you will find CB1 and CB2 throughout the body, there is this kind of general trend of CB1 in the CNS, CB2 outside. The enzymes that I spoke about a moment ago, we'll just go through these real quick. MAGL degrades 2-AG, whereas fatty acid amide hydrolase degrades anandamide. It's not really important that we get into the details of all of this, just to let you know that these are the enzymes that degrade these cannabinoids. COX-2 also will degrade them, which is interesting. And then fatty acid binding protein is really a transport mediator that moves these things across the synapse. So just to kind of walk you through how all of this works, you can just kind of follow by the numbers here. There's an action potential in the neuron. That's number one, where a calcium channel opens. That stimulates the release of neurotransmitters that cross the synaptic cleft, and then the upregulated neurotransmitters will thus open a calcium channel, and then stimulates the retrograde flux of AEA and 2-AG to the presynaptic neuron, where it then interacts with a cannabinoid receptor, and at that point, those endocannabinoids, the 2-AG and AEA, are then degraded. So that's kind of roughly the process of how all of this happens. So we'll take a break here for just a moment, just to do our first survey question. And the question here is, what is your position in the veterinary profession? Are you a veterinarian, a technician, a CSR, or something else in your veterinary office? Okay, so we have our answer. Almost everybody here present today is a veterinarian. We do have 3 technicians, so welcome to you guys, and thank you for joining this, because this is absolutely as much for you as it is for anybody else. So let's move forward. I don't know if it's going to let me do that. Oh, there we go. Okay. So now we're going to move into cannabis, the plant. Now that we've sort of looked at the endocannabinoid system, let's look at what's happening in the plant itself. So within cannabis, there are over 700 bioactive compounds. There's phytocannabinoids, which we're going to talk about in a moment. There's terpenes, quite a lot of those. Flavonoids, which are the plant-based antioxidants. And then there's some other things as well, B vitamins, essential fatty acids, etc. So, I mean, this is a plant that contains a lot of bioactive compounds. Let's start with phytocannabinoids. So these are plant-based exogenous compounds that have activity on the endocannabinoid system. And there are, as I just mentioned, there's quite a lot of them. There's over 150 of them. The ones that most of us are really familiar with and that have gotten the most attention are THC and CBD. Now, certainly, there's a lot of other cannabinoids that are getting attention right now from a research and clinical application perspective, but THC and CBD really continue to sort of dominate the field. So let's start with THC. THC is actually produced within the plant as something called THCA, which is the acid form of THC. It is then decarboxylated to form delta-9 THC, which is actually the psychoactive component of cannabis. So that's the thing. That gets people high. That's the thing that causes intoxication in pets when they get too much of it. THC it's a partial agonist of CB1 and CB2. although most of that psychoactivity is happening in the CB1 receptors in the CNS. It also has effects on opioid receptors, which has a lot to do with why cannabis can be very beneficial from a pain control perspective. Pharmacokinetically, and I'm not going to go through this whole thing, other than to say that once it's absorbed, it is distributed throughout the body, fat, liver, lung, and spleen. It goes through this stepwise metabolite process that you can see here. And most of the excretion is feces, although there is some renal as well. Physiologically, this is the list of effects that we frequently see with delta-9 THC. Probably the biggest one is its analgesic effects. It's very, very good for pain. It also has anti-cancer properties. It also can help with nausea and inflammation. You can see there's a lot of other things on this list as well. You know, there is no shortage of potential clinical applications for THC. It's just that we have to be, you know, we have to be duly cautious in its use because, again, it is the thing that causes psychoactivity. It is the thing that will cause intoxication in animals that can be quite problematic if it is in excess. When we move on, you know, we can talk about CBD, the other big player, if you will, when it comes to cannabis. Just like THC is decarboxylated THCA, CBD is decarboxylated CBDA. It has moderate binding affinity for CB1 and CB2. And one interesting thing here is it may actually prolong AEA, which, remember, is one of the naturally occurring endocannabinoids in the circulation. And the reason why that's important is because not only does CBD have its own effects on the body, but it is actually promoting the effects of the endocannabinoid system and the natural neurotransmitters by keeping those things in circulation before they get degraded. And interestingly, CBD, it may or may not actually reduce the intoxicating effects of THC by slowing the metabolism of THC. Again, we won't go into this too much, but the pharmacokinetics of CBD are really important, specifically because it is a competitive inhibitor of cytochrome P450. This is why in the clinical trials looking at CBD in dogs, it raises alkaline phosphatase a little bit. Theoretically, there are some current concerns for drug interactions, but to be honest with you, they are quite rare. Physiologic effects of CBD are similar but different than THC. There's still an analgesic, anti-neoplastic, anti-inflammatory effect. Excuse me. I think the two things about CBD that are really somewhat different from THC, it's calming, it's anxiolytic, and it also has anti-seizure properties. You know, so of all of the various things that CBD does, those are probably two of the things that it actually gets used for the most. I want to talk a minute about THCA, the acid form of THC, because it is a molecule that's getting a lot of attention. One of the big things to note about THCA is unlike delta-9 THC, it is not psychoactive. So this is something that can be used clinically in animals without that concern. And you can see the list of potential clinical applications it has here. So that makes it, you know, a very attractive molecule from the perspective of what we can do with it clinically. Of course, there is the issue that Jeff will talk about later as far as legalities with anything that looks like THC. And again, speaking of the acids, we'll just talk about CBDA for a minute. CBDA is also non-psychoactive, and much like THCA, it has some very interesting properties: antiemetic, anti-inflammatory, anti-neoplastic. So these are things that we are already seeing these being added to formulations for both people and animals. So, you know, I think you're going to see them more and more. And the more you learn about cannabis and learn to read labels and read certificate of analyses, you'll start to see these things pop up. Another cannabinoid that's worth talking about is CBG. cannabigerol. CBG is interesting because it is actually sort of the progenitor cannabinoid. It's the thing that the plant produces, and all other cannabinoids are thus created from it through chemical pathways within the plant. Again, you can see the list of physiologic properties here. This is actually just for your viewing pleasure later when you get a chance. This is the cascade of how cannabinoids are formed. I mentioned CBG is really where it all starts, specifically CBGA, the acid form, and then everything else within the plant or outside the plant is created. So all of the acids, THCA, CBDA, et cetera, are created within the plant. And then when those acids are heated or dried, you wind up with THC, CBD, et cetera. And then as those compounds age, we will wind up with other compounds that have their own interesting applications, including CBN, which has gotten a lot of attention as far as like helping people sleep, having antibacterial properties, et cetera. Moving on from the phytocannabinoids are the terpenes. Terpenes are actually the most common molecule found in the plant kingdom. These are, there's over 55,000 terpenes that have been identified, and most of them are made by plants, and over 200 of them are found in terpenes. If you're familiar at all with essential oils are terpenes. That's what you're smelling, is you're smelling these volatile organic compounds. Well, it turns out these volatile organic compounds actually have a lot of physiologic activity. They're created by plants either for protection or chemical signaling, but they do often have effects within animal bodies as well. They are actually produced outside of the plant in the trichome. So these structures that you're seeing in the picture that kind of almost looks frosted, if you will. These are the trichomes producing terpenes on the outer surface of the plant. Terpenes have enormous physiologic effect. This is why certain people get very excited about essential oils. I think a lot of people in Western medicine look at essential oils as sort of hocus pocus. It's not. There's real science there, and it's terpenes. And when you combine these terpenes with cannabinoids, you can really, really greatly alter the physiologic effect of both. So there's this whole phenomenon called the entourage effect, which really describes the effect of many, many compounds that are in the cannabis plant all at once, having an effect on the body. In fact, some terpenes act as cannabinoids. Beta-caryophyllene, for example, is a CB2 agonist. Myrcene, which is also commonly found in cannabis, can potentiate the effect of cannabinoids. So there's a lot of interplay and interaction here, which scientists are really just continuing to dig into. And as we understand this more, it's going to give us more of an understanding of how we can formulate these products to treat our patients better. So let me just take a moment here to just kind of sum this up, because I know that was a lot of information in a fairly short period of time. But the endocannabinoid system, it is a regulatory system of neurotransmitters that are throughout the body. The central nervous system, the peripheral nervous system, the heart, the gastrointestinal tract, pretty much anywhere in the body you can think of, the endocannabinoid system plays a role. And this is why when you start hearing people talk about cannabis and they talk about how it affects all of these various things and can treat all of these various things, I think as Western doctors, that's when the light in your head goes off and says something's wrong, because nothing can treat that many things. Well, the reason is because the ECS touches pretty much every system in the body. Phytocannabinoids, the things that occur in cannabis, are going to directly interact with the ECS. So that gives us, sort of an external lever, if you will, to affect how the endocannabinoid system is working. And thus we can use them therapeutically to achieve some sort of physiologic effect in patients that need help. And the last thing that I just really want to talk about is terpenes, these volatile organic compounds that have their own physiologic effects, but can also impact the effects of the phytocannabinoids. And I didn't really have a chance to get into flavonoids, but flavonoids are plant-based antioxidants that are also present in cannabis. And it is really the presence of all of these things and the combination of all of these things that really makes cannabis such an interesting herbal medicine and such an interesting way to approach medical conditions in animals. So I will take a break at that point, and we will move on to the next section.
Dr. Hazzah, you just need to unmute.
Oh, wow. I had some major technical difficulties right there, but I am good now. Thank you, Dr. Richter. That was awesome. And I cannot believe you got through all that information in 30 minutes. Like, my hat is off to you. I talk maybe either too slow or too much, but I don't know if I could have done that. So awesome. And it really is helpful that you did that, because now everyone has a little bit more of a basis to understand this part, which is the implementation, right? So now that Dr. Richter has talked about the endocannabinoid system and the importance of the endocannabinoid system and phytocannabinoids and terpenes, terpenoids, and even flavonoids, you threw it at the end, which I think is really important. Now let's talk about, how do you actually use them in practice? How do you guide a pet parent, right? Because, you know, many of us are getting, you know, asked by pet parents, how can they use it in their, use cannabis for their pets? And so it's very, very important that we have some understanding of that. So I'm excited to get right in and talk a little bit about it. So sorry, I'm trying to get this back. Okay, here you go. Okay, so what are the steps to consider when you are thinking that you want to start a patient on cannabis? And when I say cannabis, I'm just going to say this so everyone kind of understands. I'm really talking about both hemp and marijuana. Or what I would consider like low THC cannabis and high THC cannabis, I'm kind of putting them all together. If I ever am thinking that there's a specific tip or something that you need just for one of them, I'll say it. Otherwise, I'm just going to kind of say cannabis as the term to real that encompasses both hemp and marijuana. All right. So step one is we need to really be able to evaluate the patient. Does the patient actually have a cannabis responsive diagnosis? Does the patient have any contraindications or comorbidities that you need to be aware of before starting cannabis? Is there a potential for a drug interaction that you need to be aware of? And then step two is product selection. So what do you need to know about the product formats, the accuracy and consistency, and the importance of lab testing and product safety, right? We want to make sure that our patients are getting clean products. And that is, that's going to be a big part of what I talk about. And then lastly, let's talk a little bit about the different ratios and the rationale behind dosing, right? So safe and effective dosing will be the last part. All right, so step one, we'll start with appropriate conditions, then contraindications, and then I'll jump to drug interactions. So what are some of the conditions that cannabis is being used in people? Here they are, a ton, right? I mean, a ton. There was some interesting research that came out and was published in 2019 that showed that 80% of people that were taking legalized marijuana reported it to be very or extremely helpful. And 82% of the people that were taking a marijuana product were able to reduce or stop taking some of the over-the-counter pain medications, and 88% were able to either reduce or stop taking the opiate painkillers. And that is what we have started to hear when I attend some of the human physician cannabis lectures and so forth, a lot of them are looking at actually cannabis as almost kind of an exit drug, meaning that it helps with withdrawal from opiates and other drugs, alcohol even. They're looking at some of the cannabinoids for alcohol withdrawal and getting folks, off of certain drugs and alcohol. So really interesting. But as you can see, there's a tremendous list of what cannabis is being used for in people. When people say, you hear that sometimes folks will say like, oh, you can use cannabis for everything. Like, no, I don't think you can use it for everything. This is a big list, but there's a lot more diseases in people and in animals. And I don't think it works for everything. And it's not like a magic, medication or pill or tincture or whatever it may be. So I do want to put that out there. I think that you'll hear, especially some of these companies saying, oh, it works for so many things. It can cure cancer. Yeah, I would not ever, ever, ever say that to a client. And Dr. Pollard will get into all the legal stuff. But the truth is I don't think the research has supported that for any disease condition. All right, so what are the potential medical uses for cannabis in animals? I bolded 2 of them, right? But here's a long list. Analgesia and anxiolytic would be, the big ones. And why did I put that? Well, because, when you look at the studies that have been done since 2018, there are some survey studies that have been done. And what they've shown is the 2 most common conditions that owners are looking to employ cannabis for their pets is those 2, pain and anxiety. And interesting, one of the studies that came out, I think it was 2020, it looked at human patients and dog owners, and they reported similar motivation for using cannabis products to treat chronic pain. And the reasons for that were they thought it was a natural product, cannabis that is, the natural product, it was preferred over conventional medicine, and they believed that it was the best treatment and it was a good treatment option to treat pain. And then they did a poll and said, what are the percentage of, patients, either human or animal, dog patients, that felt that cannabis fulfilled their expectation. And it was 86% of humans that said that they felt cannabis helped with their pain. And it was 82% of veterinary patients that felt that that cannabis actually fulfilled their expectation of reducing, the pet parents felt that it reduced the pain in these veterinary patients. So that was a really interesting study. Again, it was a survey study. It was like an anonymous survey study that was performed. There were 2 actually done around the same time, one in Canada and one in the US, but pretty interesting information that it got. And then again, other really common reasons, anticonvulsant is huge, anti-neoplastic. And I think from the cancer standpoint, as an oncologist, I'm happy to discuss with everyone here that, people aren't always coming for a true anti-neoplastic. Sometimes they come for palliative, right? They're saying, I know my dog or my cat is toward the end, my pet is toward the end, I just want to keep them comfortable. And then there are other conditions that are listed there as well. Okay, and so this slide is super, super busy, and it's kind of done on purpose in that there are 14, currently right now, there are 14 clinical, and these are peer-reviewed clinical studies that are done in veterinary medicine. So back, in 2018, there were, and it's starting in 2017, there were 0. And then starting in 2018, there were a handful. And then since then, there's been several others that have been published. So these are these aren't in vitro studies. These are actual clinical studies in patients. And the first group, so I have a line across, the first group are all looking at osteosarcoma, osteoarthritis. The oncologist is speaking, so I go right there. It's osteoarthritis, the effect of cannabis on osteoarthritis. The second little group is seizures or the drug interaction with some of the anti-epileptics. So the 2 on the bottom are more, the safety and efficacy. The first one, number 6 and number 8 are looking at clinical evidence of it working. And then the 7 and 8, the last 2 are looking at both, the potential for drug interactions. And 8 also talked a little bit about that. And I'll get into that in the upcoming slides. And then the next group is more behavior. So like anxiety, the effect of cannabis on anxiety. And number 11 by itself is looking at the effect of cannabis on the microbiome, which is really interesting. And then lastly, the 3 on the bottom are derm studies. So there is clearly some evidence that, I mean, people are trying to look and see if cannabis is effective. And so I will say all of the studies that you see here are using a hemp-derived product, right? Because there are other studies like PK and safety studies that are looking at dose escalation, even marijuana type products, or safety of marijuana type products. But these particular clinical studies are just hemp-derived. So I just want to throw that out there. All right. Contraindications. What I really want everyone to remember, the biggest contraindication that I have found, and what has been published in the human side too, and going to some of the human conferences, is cardiac. Like, that's the big thing. And it's not mild cardiac disease. So the dog that comes in with, mild mitral valve disease, even moderate, mitral valve disease, those aren't the ones we're worried about. We're worried about the ones that, at least in my experience, and I'll speak to my experience, and I'll talk also about what's been published, is that in my experience, it's the ones that are, teetering like in and out of heart failure. And that's not just dogs, cats, absolutely. I had a cat that came to see me at Green Isle for a consult for aural tumor, an ear tumor. And this cat, for some reason, someone had guided, maybe it was at a dispensary or something, guided this pet parent to use a high THC marijuana product. And the cat, after a week or 2 of being on the product, ended up going into heart failure and had already had a history of going into heart failure. So those are the cases that we want to be very, very cautious. And THC tends to be the one that creates more of the problem, but CBD also, and specifically at higher doses, can cause some tachycardia. And then chronic users, and this has been found both in animals and in people, can cause some bradycardia. So obviously we're not so worried, and it's not profound bradycardia. They're able to, still function. It's the ones that, a lot of times I'll ask the cardiologist, like, hey, if this dog or cat ends up having tachycardia, what's going to happen? If they're like, oh, they'll go into heart failure, well, then that's not the case. That's the case that you want to be extra, extra careful. And does it mean that you don't use it? Maybe not. Maybe you're just very, very careful with dosing, and your ratio might be that you have either, a very low amount of THC and a higher amount of CBD. Again, just ratio, not dose, that we'll talk about in a little bit. There are some studies that have been published looking at CBD being cardioprotective. And those studies tend to be more like mouse model, like rodent model studies. And THC, one of the studies is actually a rodent model study looking at THC at something like, I think it was like 0.002 mg per kg was cardioprotective. And so the problem is, I don't know what that is, what that dose is in veterinary, in our small animals. So I wouldn't be able to say start at this dose. So oftentimes if an owner is concerned, I'll kind of guide them and say, maybe try to stay away from THC and use super low doses of CBD to get started, and maybe very, very slowly increase the dose. And we'll talk a little bit about dosing rationale toward the end. Cannabis could exacerbate arrhythmias as well. It can cause changes in the blood pressure. So again, these are all really cardiac. The one thing I don't have on here, because it's not, it's not at least to my knowledge, not necessarily been published, but something that I'm always still concerned about is if they're like fulminant liver failure, I would be very careful, because the liver actually metabolizes many of the cannabinoids. And so I think that just being cognizant of that and understanding the pharmacokinetics of the cannabinoids, the phytocannabinoids, will help kind of guide you. But that would be the only other case. Usually it's cardiac that kind of gets my attention and helps when I'm guiding a pet parent toward, the risk versus the benefit, right? So you have the conversation. If they're using it for palliation and their pet is really suffering and they think that it's going to help, then, and if you feel comfortable, and Dr. Pollard will probably, tell you, explain this in much more detail. But I think if they're asking you, just make sure they're informed of the potential of worsening the heart disease. So that is, I'm on purpose spending a little bit of extra time here so that gets across. And then obviously in patients that are pregnant and breastfeeding, I don't think we know enough. Even in the human side, there's mixed information regarding that. All right, so drug interaction. I think that Dr. Richter brought this up and said, generally we're not worried about drug interaction, and I agree with him fully. Like, I am listing all of this information because it's published information just to make you aware. But the reality is, despite so much of this, we really don't see drug interactions. I mean, if we do, they're usually pharmacodynamic, right? Meaning that you might notice, and we'll talk a little bit about it, like the sedatives, for instance, right? You may end up, having dogs that are, say, dogs or cats that are on gabapentin or tramadol or something like that. You may find, or Valium or any of the pain sedative type medications, you may notice that if they're given cannabis at the same time, that they're a little bit more drowsy or lethargic or sedate. But it's not necessarily a pharmacokinetic type reaction or interaction. We do know that the expression of some of the membrane transporters were found to be dysregulated by cannabinoids. And, it usually requires so much higher concentrations for that to happen than was ever measured in studies that were done with cannabis smokers or even some of the oral. So, and I think in the veterinary side, we don't really use super, super high doses. Generally, we don't, but it's just important to know that the multi-drug resistant protein, for instance, can be affected. CBD is a really potent inhibitor of some of the multi-drug resistant P-glycoprotein. So just something to kind of keep in mind. There are some studies, human studies, that have come out looking at both actually CBD, THC, and CBN, all inhibiting P-glycoprotein. I have used, one of the questions I usually get after saying that is, how do some of the sighthound and MDR1 or ABCB1 mutant animals do with cannabis? And they do perfectly fine. We do not notice any issues whatsoever. And there's actually a published study that's going to come out in the near future that will explain a little bit about that. Regarding cytochrome P450, just know that THC and CBD are both metabolized by cytochrome P450, and they both are metabolized by the 3A4 component. And, THC is metabolized by the cytochrome 2C9. And the reason why some of that is important is there are other drugs that inhibit, so ketoconazole, right, that works on 3A4, or fluoxetine, right? So that works on cytochrome 2C9. And why is that important? Well, when I talk to clients about this and they're on these medications, I will say, hey, heads up, if those enzymes are going to be inhibited, then there's a chance that I'm going to have higher levels of THC floating around, right, in the body. And there might be a little bit of an increase, of THC exposure for that patient, and potentially some of the psychotoxic effects. CBD, I guess I worry less about. So it's a little bit of it can be a bit confusing in that they both can inhibit cytochrome P450, especially CBD even more potently. But they also their levels can actually go up because they are being metabolized and induce P450 as well. So something to just keep in mind, and just understanding the drug interaction component. Again, I have clients that have asked me before about using, Prozac with cannabis, and I'll usually say, like, look, just give them apart, just be careful, there's a potential for drug interaction. And then they don't listen and they do it, and guess what? The patient's like totally fine. We need obviously like well-controlled studies that look at levels of these drugs to confirm, like they did in the anticonvulsant studies, to really confirm that you're not getting increased levels of either the cannabinoids or the pharmaceutical. All right, I'm going to just move on. You have a list though of some of the others. Here's a fairly large list. I would skip the ones that, look, we don't have any patients that we are treating that are consuming alcohol. But for you all to know, alcohol has the potential of increasing THC levels. So if you're going to do both together, just keep in mind that there's a higher chance that you're going to have some of the psychotoxic effects. One of the interesting studies that came out was actually looking at the sedation column. So they looked at medical records of 250 patients, and the research has compared regular cannabis users versus non-users, and found that cannabis users required 14% more fentanyl, 20% more midazolam, but look at the propofol, 220 times more propofol to get through the endoscopy. So that was an interesting study. And when that came out, I remember asking our radiation oncologist, like, hey, give me a heads up if you're seeing that any of the patients that are on cannabis from me or, with my support, you're noticing that they need more propofol because they're also undergoing radiation. Some of these patients would have just started it or had been on it for several months. And he'd always tell me like, nope, they just need the same amount. So I don't know. I don't know if chronic might mean like they would have to be on it for a year in animals. Like, I don't know, but I just think keep that in mind that study does exist. Immunotherapy wise, obviously, I've looked at all the cancer stuff as well. So there was no interaction with chemotherapy. They looked at 2 different chemotherapies, docetaxel and irinotecan, and then there was no interaction. And there's other studies that look at actually synergy or additive effects with chemo. So I'm never concerned about using cannabis with chemo. One modality I am though concerned about is the immunotherapy. And I think even on the human side, all of the human physicians I've spoken to are also like, we just are a little bit worried because of a study that came out in 2019. And basically it just showed that the users, the cannabis users that were on immunotherapy, they had reduced response rates. It interestingly didn't really affect progression-free interval or overall survival. And these are patients with advanced melanoma. They had lung cancer, they had renal cell carcinoma. And in that particular paper, there was 140 patients. And they compared the ones that were on this particular monoclonal antibody, nivolumab, versus nivolumab and cannabis. So just to throw that out there, I will say that no one's done a study to look at vaccines and looked at titers or any of that. So that might be something that someone would want to do. But just from the oncologic standpoint, we utilize the melanoma vaccine. So that's always a conversation I have with owners, like, again, risk versus benefit. And then the last would be anti-epileptic drugs. And that's a long column, partly because there has been a lot of studies. And in the veterinary space, that's the first 3. Right. So interestingly, phenobarbital, like I talked about, right, we all know is an inhibitor of cytochrome P450 at 3,4-A. And what we know, or 3A4, sorry, and what we know is that when they tested the dogs that were on cannabis and they were getting 2.5 milligrams per kilogram of a full spectrum hemp-derived product, and they had no statistically significant increase in phenobarb levels at all. They didn't do PK of CBD levels in that study. They just looked at efficacy, but it didn't affect phenobarb or potassium bromide. And then a secondary study was done in 2021 that looked at if there was an interaction, like a pharmacokinetic interaction between CBD and phenobarb, and there was none found. And then the last study was just published just this year that found there was no interaction between a combination of CBD and CBDA with 3 of the drugs, phenobarb, potassium bromide, and zonisamide. And I thought that was a really good study, partly because I was always a little bit weary about zonisamide because of the bottom study that was done in children and adults. And what they found is that zonisamide levels did go up. And so I was worried if that was going to happen. It was not found in children with zonisamide. I don't know. It was just found in the adult patients that were in that particular study. So kind of interesting, right? Like, I always thought, should we adjust the zonisamide levels? But clearly I wouldn't. And I think the conclusion in that veterinary 2022 paper was like, there really needs to be no dose adjustment of any of the anti-epileptics. And then the other drugs, so valproic acid caused liver issues, and clobazam had higher levels in these kids that were on CBD, but we don't really use those in veterinary medicine. So I'm going to keep going. All right, step 2, product format, product selection, and safety and testing. Here is a long list of the different formats. You can give raw, you can give a tincture, which is the most common form because it's easily titratable. edibles like treats and chews and things like that, dental chews, the whole thing. I mean, you see it there's like so many different formats at this point. Generally, we say stay away from edibles for humans that are made for humans, because you don't know what else might be in there, xylitol and some other things. And then, just a quick recap of what these terms really mean. Full spectrum generally means that it's a product that contains THC and usually other cannabinoids. The true definition is not necessarily what is being used out there and what companies are referring to. So that's why I'm just gonna kind of give you the general terminology of what is commonly used, which is it should contain THC if it's full spectrum. The real definition should really be what the plant was grown to contain, should be all in the product, which is not what we typically see after processing and extraction and so forth. Isolates, so single compounds, usually 99% of that particular compound. And now it's not just CBD. You can have isolates of any cannabinoid almost that are commonly used. And then broad spectrum is generally a way to describe products that have no THC and have CBD. Again, there are lots of companies that are using labels like that, but it's not necessarily accurate. So this was a 2021 publication that showed that only 44% of the tested samples contained the advertised amount of CBD, and the rest were between 10 and 98% from the label. And then 22 of the tested products had no THC, despite the companies claiming that it was full spectrum. So when if you're thinking, oh, I want this patient to have a little bit of THC because of X, Y, and Z, they need an appetite stimulant, or they have severe pain, or whatever it may be, well, guess what? You need to be able to really look at the certificate of analysis that we'll talk about on the next slide and really get a very good idea as to what the heck is in these products, because the label is certainly not always accurate. And going to dispensaries, the good example was like that cat, right? That I told you about, that the dispensary, one of the bud tenders at the dispensary decided to tell him to start a THC product that was higher in THC. And so, it's really sad that that these pet parents are getting advice from, folks that don't have the proper training. So how do you actually know what's inside the products? You need to look at something called a certificate of analysis. And that is something that all companies should provide. And honestly, my opinion is it needs to be provided on the website. It needs to be divided into batch numbers. So if you were to buy a bottle of X, Y, and Z, or a bag of treats, or whatever it may be, or a pet parent does, then you can compare the batch number to what's on the website, and you can tell exactly what is in that product. You'll need to it will tell you the potency of cannabinoids and terpenes. If it's free of contaminants, pesticides and fungicides and bacteria and residual solvents, right? So a lot of these products are being made with alcohol, so ethanol. So sometimes you can have trace ethanol. Also butane. I was just recently I did a consult for an owner that they were saying, oh, I've been giving this to my pet and but it's not working as well. And so I always look up what they're on. And I oftentimes will share my computer screen with the owner so they can see what I'm doing. I find the COA for the companies that have it available. You want to make sure that there's the certificate of analysis is from a third-party laboratory, not in-house. So it's not like the manufacturer just tested their own stuff and said it's safe. You want it to be from a third-party, non-biased laboratory, and it can be very clear that would be the case from the laboratory. The name will be on there, the batch number, all of that will be on there, and you'll be able to confirm that there isn't any contaminants. So that case that I spoke to that pet parent, I showed them the certificate of analysis we were looking through, and there was actually like residual butane. And I was like, okay, I don't think that this is probably the safest product, especially because it was for something like an arthritis case that was going to be giving it chronically, and the pet still had a long way to go. It wasn't like it was on its last week or anything like that. So this is important. And I know we're all very, very busy. So sometimes that might require you just informing the owner, right? Educating the owner on the importance of making sure these products are safe. And then lastly, looking for heavy metals. a lot of these plants, especially the hemp-derived plants, they can be really poorly grown or cultivated. Not all of them, but some of them can be. And a lot of times the soil can be contaminated with heavy metals, so lead and things like that, and other heavy metals. And they can, the cannabis in particular, hemp, can really suck up everything that is in the soil. So it's called a bioaccumulator, and that is one of, like, if you think about it, if you had really like dirty soil, you could plant a ton of like industrial hemp plants, let's say, have it suck up all of the heavy metals, and then you could kind of start a little bit more fresh. And that's how strong they can do that, is they can really pull up everything. So there was an interesting study that was published in 2020, that it was a veterinary study that tested 29 CBD products, and they actually found heavy metals in 4 of the 29 products. And lead was the most prevalent contaminant at 3 out of the 4. So just keep that in mind. It doesn't, because it's a veterinary company, doesn't always mean that that it's free of contaminants. All right, last slide until we go to the next section is going to be talking about product selection. So how do you know, like, how do you guide a pet parent toward good products? Well, first is defining companies that are transparent, that have available certificate of analysis, that are, organized in batch numbers, that, not just, so some of these companies will literally just have a potency, but doesn't have a safety. So then I say, well, that's kind of odd. Well, how do I know if it's safe? It looks like it's exactly what I want. It has the, the potency of CBD or THC or other molecules, but I don't know if it's safe. So you want to make sure that all of that is transparent, that the brand has some reputation, that there's a veterinarian that's involved. I think that so many of these companies kind of came into the space to just try to make a ton of money because it's the fad, right? And look, I believe in cannabis as medicine for certain disease processes, but a lot of companies didn't come into the space for that, and therefore they didn't take the time to necessarily get the right folks involved in making sure that the products are safe. And therefore you'll see things like butane or, certain flavoring or things that might not be necessarily safe for pets. So when you have a veterinarian involved, at least for me, it always makes, in almost anything, like when I, talking to, certain drugs that have come out in the oncology space, if they don't have any oncologist backing them or any veterinarian backing them or any, any supplement or whatever it may be, it makes me just a little bit nervous. But when there's a veterinarian that is involved, it just makes me feel a little bit more comfortable because we have the knowledge, right? We have the knowledge more than, someone that hasn't gone through the schooling. So does it have the molecular profile that you're interested in? Does it have the desired ratios that we'll talk a little bit about? Does it have the diversity of cannabinoids and terpenes? Is it truly full spectrum? That's what I mean by that. Does it have lots of different cannabinoids and terpenes, or is it just more like a CBD isolate and you were looking for something different? Does it have the appropriate potency? Well, some of these products might only have 3 milligrams per ml of CBD, but you have a 70-pound dog, and the dog might need closer to 30 milligrams of CBD. And so you'd have to give them 10 mLs to get there in that particular formulation, versus if you found one that was a 30 mg per ml, you give them 1 ml. Or if you found with a 60 mg per ml, then you give them half an ml. So dosing is going to be important. Ease of administration, right? Is it at the potency that will make it easier to give? Is it at the format? I have a cat patient that will not touch any cannabis formulation, regardless if it has terpenes or not. They do not like the taste, right? Remember, terpenes, as Dr. Richter said, is what provides the taste and the smell. And so a lot of these cat patients, they're really sensitive to terpenes, and they ended up using some sort of treat that worked better, or they eventually found a product that didn't really have any terpenes and is actually working awesome for the cat. But some dog patients are also super sensitive to certain products. They won't eat certain treats, and you want to use a tincture instead. So just making sure that the product format matches that patient. All right, so I'm going to jump to poll question number 2. Are you comfortable? And now that I think it was 94% of the folks in the audience are participants are veterinarians, and then we had 3 technicians. So everyone, please feel free to answer. Are you comfortable with your understanding of cannabis to provide an accurate information or guidance to owners who are interested in using cannabis for their pets? Yes or no? All right, so it looks like more than half, 64%, are not comfortable using cannabis for their to guide pet parents and how to use cannabis. And this is why you are here today, and I thank you for being here. The folks that are in that 3rd group, thank you also for being here, because there's always more to learn, right? I go to these conferences and I read books. I just came from vacation and I brought a cannabis book for me to read, and that was fun for me, right? Like, there's always so much to learn. So thank you everyone for coming tonight and you know, being open to learning more about this. And so hopefully this will help bring up that number, or bring down, sorry, the number of the 64 down, you know, to more, you know, to less, or bring up the number of the folks that are starting to feel a little bit more comfortable to talk to pet parents about it. All right, so I'm going to go to the next slide. All right, we are at the last step, step 3. So this is where I'm going to talk a little bit about the ratios and some of the dosing rationale and what biphasic dosing curve really is. So I decided to start with this slide because you hear a lot of times folks talking about, you know, different ratios, to use a high ratio, low ratio. So I wanted to explain what it really means. And so generally when folks say a high ratio, they generally are talking about CBD to THC, meaning you're going to have a larger amount of CBD to THC. This number 12-to-1 is not published. I came up with it. That's what I use in practice, is where I say, look, anything above 12-to-1, I think in the human space, some of the physicians are using 11-to-1. So I somehow have always in the last few years kind of gone to anything above 12-to-1 would be considered more of a high. What is the, you know, the most common ratio that you see with a lot of these veterinary hemp derived products are more like 30, 40, 50-to-1, but 30 to 40-to-1 is probably more common. And so what are those formulations probably best for? Anxiety seizures without a doubt are like the highest on the list, and that's why they're the highest on the list. Because if I have a seizure case, I talk to pet parents, I educate them on the importance of how CBD works and the different mechanisms behind how CBD works. THC does have the ability to have anticonvulsant activity through anti-glutamate activity. However, it does not work as well as CBD for chronic use, and you don't need a patient on a ton of THC to get the efficacy you're looking for. And so the goal really is to reduce the potential for side effects and increase the potential for efficacy, right? And to do that, why use a lot of THC if you don't have to? Because CBD generally has less side effects than THC. So other conditions are listed there for you. Cognitive dysfunction could probably go into that. It's usually in the high CBD THC, but could potentially go into the next column. Certainly, I wouldn't ever use a THC dominant product for cognitive dysfunction. And then you'll see pain is throughout all 3. I think, you know, with the high CBD THC, so you're, you know, 18-to-1s, 20, 30, 40-to-1s, I think probably better for more the mild to moderate ones. If you start to have more moderate pain, you need to start going into the low CBD THC to what they call even ratios, like a 1-to-1, 1 part CBD, 1 part THC. So anything under 12, I would probably consider a low CBD to THC, or lower is probably the better term. And that would be things for, like, again, anti-neoplastic activity is throughout all 3. And honestly, it's because that it's really cancer dependent. So cancer type. And oftentimes I just use research to help kind of guide me, which then there educates the pet parent as to which cannabinoids and which ratios make maybe the most sense for the specific cancer. Palliative support, certainly I think you're going to get more positive effect with a low CBD THC or even ratio than you would with a high CBD. And then some of the GI diseases, I find I get really good response at like sometimes a 3 to, well, let's call it maybe a 1-to-1 all the way up to an 8-to-1, a 10-to-1 for some of the IBD cases. If they're older and have a lot of comorbidities, I tend to go with higher ratios, so less THC. And then I just slowly increase the THC and essentially reduce the ratio as time goes on if you're not getting the effect you're needing. But if you're getting the effect, you don't need to change it. If the, a good example would be my own cat. I have a cat that has, chronic vomiting and, and they always say, like, if a cat's not a cat if it doesn't vomit, but if it vomits multiple times a week, then obviously there's an issue. So I brought him in, he had an ultrasound and he had what was considered probably early IBD per our radiologist. And he went on cannabis and, within probably 2 weeks, he stopped vomiting. And literally was vomiting once every 3 months. I mean, it was incredible. And I went back maybe 2 or 3 months later and they did an ultrasound, his intestinal tract was normal. And I was like, geez, if I wasn't a believer before, now this seems work. Does it work for every animal with IBD? No, it doesn't. And does that ratio work for every animal with IBD? No, you sometimes have to go higher or lower or add in different cannabinoids. CBG tends to be really helpful for the gut, and certain terpenes can be really helpful for the gut. So that's my story to tell, but there's certain cases I've treated where some clients have said, oh my, and ultrasounds have confirmed and so forth. There are certainly improvement, and then others where we're having to, do like a trial and error and figure out which other product might be more effective. And then lastly, CBD dominant. The only thing I will say about that is it's never, and I'm going to use the word never, you're never going to start a pet on a CBD dominant product. It's honestly, it's not going to happen because they're going to get high, they're going to get intoxicated. And so you're going to have to start at either a high CBD THC or a low CBD THC, and then eventually get to a THC dominant. So that has happened with appropriate titration, where you can start to treat some of the severe pain cases and stuff like that, where you start maybe at a low or even ratio and then slowly start to incorporate more THC. So I have certainly several patients that have done that, but those are the conditions where I would consider THC dominant or a 1-to-1 being probably more effective. Biphasic dosing, the only thing you probably need to remember about this is it's very different than pharmaceuticals. So pharmaceuticals, they're dosed more in what they call a linear dosing curve. So essentially, as you increase the dose, the efficacy increases until you reach a maximum level of efficacy. If you dose above that with a pharmaceutical, you usually will get side effects, but you won't really get any improvement in your efficacy, right? You kind of have little or no improvement. With cannabis, what ends up happening is if you go above, so same type thing in pharmaceuticals, where as you increase the dose, right, you start to find what they call the optimal dose. But once you go above the optimal dose, you actually lose efficacy. So you can have a case that's doing so well and the owner continued to titrate and they said the case is doing terrible and now it has side effects and have no efficacy. So it's very important that we start low and we go slow, right? So we increase the dose very slowly with a titration schedule. So with full spectrum products, I usually talk about the importance of this microdosing or low dose. So starting very low and slowly titrating. And the rationale behind that is what I just discussed with this biphasic dosing curve with full spectrum products. But it essentially what they call opens or widens a therapeutic window. And that's the window is in between where you won't get the response, right? But before you get any adverse events. So that's really the best way to do it. And the titration schedule generally, depends on the case and depends on what you're treating and all of that, but 5 to 7 days is pretty common. However, there's some cases where I've done 2 to 3 days. And then there's some where it's the heart disease cases and really sensitive cases where you're waiting 14 days in between titrating. THC is always our limiting factor. We can't go up too quickly, or you can't start too high because they will have intoxicating side effects. And to go back to Dr. Richter's presentation, endocannabinoid tone, so they're tone the amount of cannabinoid receptors and endocannabinoids and degrading enzymes, right? That tone is set for that patient and can be modified, or changed in some way based off of epigenetics. So your stress level, your what you eat, your exercise, that can change your endocannabinoid tone. I can't dictate that, or I can't guess that for a patient just looking at them. So I may have to either dose higher or dose lower based off of that particular patient. It will be lovely the day that I can just run a blood test and see a patient's endocannabinoid tone, because that would help in guiding me how to dose these patients. So remember, optimal dose, start low, go slow, get us to homeostasis, get us to our optimal dose. Always really important that you give cannabis with the meal. It increases absorption. Depending on the study, you look at 3 to 4-fold, if not more. So is cannabis right for your patient? Let's go through that final checklist. Does it have an appropriate cannabis appropriate diagnosis? Are there any obvious contraindications that you may be concerned about, or drug interactions? What's your clinical impression? Use your gut, right? Is it a really debilitated old patient with tons of comorbidities? Let's start them really low, maybe. Go slower in your titration. Is it a really sick patient that just needs palliative care? You might want to start middle of the road and titrate them a little bit quicker. What's the patient's temperament? And I threw this in there because we all know what this means, pet parent temperament. Are they going to tolerate side effects or not? If they're not, then maybe you want to start lower. I have some clients that want to use very high amounts of THC and they just need some guidance and they're not afraid of toxicity. We talk through what to look for and what are the specific side effects to look for. Do they have access to safe and tested products? Do you guide them on safe and effective dosing? What does that look like for that patient? And then at the end of the day, I think just like anything else, we want to set clear expectations with the owner. We want to make sure that they know this isn't going to cure their pet or may not cure their pet. And what do the studies show? What does your experience show? Making sure that they are not thinking that this is going to be that magic bullet, and that that it may take a trial and error period to find the right product. And so that's a really important point, that you always want to set something, make sure the owners are set up with proper expectations. So I went a little over, so I'm sorry, Dr. Pollard, I'll let you go. I'm gonna end the show right here, and then I will stop sharing so you can jump right in. Thank you, everyone.
All right, so we will get going here in just a second. Let me find my slide. All right. Share screen. Okay. Again, thank you all for participating. I hope this is going to be a valuable addition to the program. I will start by saying this is a California-centric, but we'll cover other states that have legislation or language also. So it is going to be mostly California, though. So our goal tonight is to provide as accurate a picture of the current state of cannabis hemp use in veterinary practice. One of the themes, one of the takeaway messages I think will be important is on this slide, and that is the federal and state laws just aren't in sync. The list here of acronyms, like everything in medicine, includes lots of laws and authorities under which we practice. You're familiar with some of them. Maybe a couple that are unfamiliar. The FD&C Act is Food, Drug, and Cosmetic Act, which in 1938 gave the FDA authority to oversee the safety of food and drug and medical devices, cosmetics. and DSHA. DSHA is the Dietary Supplement Health and Education Act. It's about 30 years old. We'll discuss that in more detail. And then everybody knows their state board governs their license. We don't all think about, however, there are other boards that have some oversight. Pharmacy comes to mind. There are other health and safety codes that control our actions, radiation treatment, and even having X-ray machines. Public health has a word when we talk about writing health certificates for patients. Of this list, both federal and state laws, the only one I'm going to mention in some detail is the first one, Proposition 215, which if you're in California, you may recognize. California became the first state to legalize medical marijuana, also known as the Compassionate Use Act. It allows patients with a valid doctor's recommendation to possess and cultivate marijuana for personal medical use. Note the span of time. That too was almost 30 years ago. The last law on the list there you're undoubtedly familiar with, called the Farm Bill, which also we'll discuss in more detail. So in California, what we do with regard to cannabis and hemp is governed by the board's guidelines that were effective about 2.5 years ago. They were formulated in response to the law listed there, AB 2215, which in a sentence allows us to discuss but not recommend the use of cannabis in vet patients. And I want to hearken to something Dr. Hazzah mentioned with regard to terminology. Like her, I too consider cannabis the umbrella term, and the divider between hemp and marijuana is that 0.3% THC content. However, we have to be careful. This law is a perfect example. The 2215 law, under which these guidelines are written, uses the word cannabis and they mean marijuana. So last thing I'll mention on this slide that we'll discuss further is the pending legislation, which is a law called AB 1885. It will essentially extend our rights from discuss to recommend. It was exited from the legislature yesterday, which is when the California session closed. It means that it goes to the governor's desk, assuming it was passed, and he has 1 month to sign it. So on September 30th, we in California will know if we can also recommend. I apologize for the busyness of this slide, and I won't hark on the details there except to hit the headlines. These are what are necessary in these guidelines, and a link to them is in the library, so you can read it at more leisure and in greater detail. But there has to be a VCPR, meaning the client has to have allowed you to examine and treat the pet. There has to be an exam. You have to record your findings, and if you've discussed anything about cannabis, you have to write that down. The conflicts of interest is mostly a financial element, and then we aren't permitted to advertise. This slide details more info about the guidelines, but it's especially important to recognize, back to my comment about the guidelines referring to cannabis, there was a push by the California Veterinary Medical Association to have the board give veterinarians and public members greater clarity on what we could do with hemp. So there's what I call a carve out in the guidelines. It's on page 2. You'll see it in the library. And it essentially describes the fact that hemp is not cannabis in the context of this law. It's regulated differently. The overseers are the USDA and then the state equivalent here, it's called the California Department of Food and Agriculture, and of course the Veterinary Medical Board. This paragraph is the result of several meetings with the Veterinary Medical Board over the last year, and it has been a helpful synthesis of what the current, I'll call it a position statement, that the board is viewing hemp-derived cannabinoids. Essentially, omega-3 fatty acids and glucosamine chondroitin would fall into the same category, and that's how the Veterinary Medical Board is viewing hemp-based products at this time. So leaving California, there are 3 other states currently that have codified legislation. Again, a link to the laws are in the library, but these one-line sentences pretty much synthesize them. Michigan uses the term consult. Utah, like California, uses discuss. And Nevada's language describes discuss, recommend, and administer. So that's 4 of 50. This page lists another 12 or 13 states, 2 of which have pending legislation, or more correctly, I should say had legislation, because both in Rhode Island and New York, the laws were either held up in committee or pulled back. So they will not be on the governor's desk in those states for this legislative term. And that's a note to remind me to just make sure that not everybody recognizes how state legislatures work. There's typically elections in the fall that determines who the participants are when the session opens the following January or February in some states. Depending on the state, it may go for several weeks, it may go for several months. Like mentioned a moment ago, in California, it goes through August, and then any legislation that hasn't passed out of committee and been voted on is either killed or carried over to the next session if it's possible in those states. So the other important thing I'd like to mention about this slide is to recognize the difference between a VMB and a VMA. So the Veterinary Medical Board is tasked with public protection. We all know them. They examine and license and discipline veterinarians. The VMAs are the state organizations that represent and advocate for DVMs. Sometimes their goals coincide, like in the case of the cannabis guidelines I mentioned, the CVMA was very helpful in getting our current language. These states that are listed here, again, a link is in the library, and you can read literally the language that either of the board or the VMA of that state has put out. They're very different, which I don't think is a surprise. I also would note that there isn't any, if you had to guess which states were permissive and which were restrictive, I think that would be a hard task. I will tell you that South Carolina probably is one of the more restrictive. And when you go to their website, you'll see, interestingly, a very detailed, long description of what the veterinarian can and can't do. I recognize the language. It comes from the FDA websites, and it's really excellent. Even though it's not very permissive, it at least gives South Carolina veterinarians some direction. Washington State, on the other hand, if you go to their website, a state that probably has a more they have a statement, and I'll quote, "Due to confusion
looks like we may have lost some sound. Give us just a minute. Dr. Pollard, looks like we have lost him. So I'm going to share, give us 1 second while he gets back in the room. I apologize, everyone.
And if anybody has any questions, feel free to throw them into the chat. Because we've been all answering some of your questions, but if you have any during this time, feel free to throw them into the chat. And I think one of the questions I'm actually answering right now from Genevieve Fox is a question about, are there any guidance on low starting doses for common indications? I thought that was a good question. I was just writing you back. And you know, it's tough because I said it really depends on the condition itself, the severity of the condition, the patient's age and weight. And so it's so hard because I guess I would say for let's say for OA, if it's kind of mild to moderate, I generally, and it's an older patient, I would probably start CBD at like a 0.3 milligram per kilogram dose. Like I don't start at what's been published at 2 mg per kg or 2.5 mg per kg or any of that. One of the studies that was published in 2019 actually showed that some of the patients responded as low as 0.3 mg per kg, and a lot of them responded between 1 and 2 mg per kg. So BID, sorry, the doses are BID. So I generally, again, some of it has to do with how much time you have, right? If it's an owner that's paid, if you know you have some time to work on the patient, it's a sensitive patient, the owner's conservative, whatever it may be, then go lower, right? Start at the 0.3 milligram per kilogram dose of CBD BID, realizing that THC is your limiting factor, right? So what that means is when there's a product and you have the owner pull the certificate of analysis, if there's 2 milligrams per ml of THC, it may not be there. You have to kind of do the math and make sure you're not starting THC very high. And so what does that mean, THC very high? I think, again, it depends on a lot of these factors, but I probably, if you had an old kind of debilitated dog that has a lot going on, let's say does not have any heart disease, let's not throw that in there, I probably wouldn't want to start more. I would definitely start less than 0.5 milligrams, not milligram per kilogram. So I want to make that very clear again. THC, I never dose in a milligram per kilogram. Other people may, I'm just speaking for myself. And THC would be like maybe 0.2 or 0.3 milligrams, not milligram per kilogram. So I hope, Genevieve, that answers your question and kind of gives everyone a little bit more information on that question. Dr. Pollard, it looks like you're back, so I'll let you continue.
All right, sorry about that.
And Dr. Pollard, I think just based on losing your audio a little bit, it may be best if I share. That way it takes less data from your internet connection and hopefully gives you a better chance to continue.
Great. Could you go to the poll, Ciara? That'd be great.
Okay, yep. There we are.
All right, so third poll question is, do you understand your state's Veterinary Medical Board position regarding cannabis? Interesting. Well, that's better news than I thought. So let's see if we can get the remaining 50% on board. Moving on to federal, leaving the states. The Farm Bill mentioned a moment ago is the 2018 law that carved out hemp and removed it from the definition of marijuana in the Controlled Substance Act. But back to the federal and state laws being out of sync, the Farm Bill explicitly allows the transfer of hemp-derived products across state lines. Yet the FDA considers it unlawful under FD&C Act to introduce in interstate commerce food, including animal feed, to which has been added a substance that is an active ingredient in an approved drug product. So no concordance there. Next slide, please. DSHA, mentioned in the beginning, Dietary Supplement Health and Education Act. Some of you may recall a very influential senator from Utah named Orrin Hatch. He was the sponsor of this bill. He just recently passed away. It defined dietary supplements as food and not drugs, but it does not apply to animals, as this little addendum 2 years later in the Federal Register lists. It was kind of a compromise between protecting the resources involved in bringing a new pharmaceutical to market and yet permitting reasonable access to dietary supplements for the public. It really has been the driving force behind some of the confusion that we operate as veterinarians, I would say. Next slide, please. So these next few slides are some variation of the big player on the federal scene, which of course is the FDA. They still maintain control over both hemp-derived cannabinoids and marijuana-derived cannabinoids. As you see on the slide here, those statements come right from the FDA websites, of which there are many pages. They're regularly updated. There are links to all of them, both these slides and then more information on the FDA. And I will, I'll refer to a couple of them in the next slide. So most of us are familiar probably with the Epidiolex. This is a CBD isolate approved by the FDA in 2018 for the control of two very severe pediatric seizure activities. This CBD is from the marijuana plant, and as mentioned, it's FDA approved, as are the three synthetic drugs. These, all four of them, are controlled drugs. Epidiolex is a Schedule 5, Marinol is Schedule 3, and the two others are Schedule 2, each of them. We as veterinarians have the right and legal ability to prescribe any one of these off-label under MDUCA. I would be curious when we get to the Q&A if any of you have done so. I can tell you that Epidiolex, when it came out, the manufacturer GW Pharmaceutical estimated the cost is $32,500 per year for humans. And while I don't have a source, I've heard anecdotally that a 60-pound golden retriever will cost about $20,000 a year. So I suspect that one isn't high on any of our lists. The synthetics, though, I don't have costs for those for you. Next slide, please. So the FDA regularly will survey and review products that are out there. They will regularly send warning letters. The date on this slide is probably the most current. It's only a few months ago, but the first warning letter on the FDA's website was sent out in 2015, which even predated the Farm Bill. And they've done studies like this slide details, even identified products that have not the amount of CBD that is on the label, or there are contamination issues, or there are unsubstantiated therapeutic claims. Quality control is a big deal. It still is the wild, wild west of cannabinoid and hemp cannabis writ large. Next slide, please. So if a product is on the market and the manufacturer wants to sell it, if they call it a food, the FDA prohibits introduction of that product in interstate commerce if it contains either THC or CBD. Again, different from some state laws, certainly the Farm Bill writing. If they want it marketed as a drug, then it has to have pre-market approval from the FDA. And I would, let me go to the next slide and then I'll give you an example. So approval from the FDA for a product is going to hinge on these three items: intended use, labeling, and marketing. And if it is called by the manufacturer a drug by either expressed or implied claims, meaning the manufacturer says it's going to diagnose X or treat Y disease, they have to, like I said, have FDA pre-approval, and that means data. That means years of studies, and that's the way the FDA approves any products, some faster than others. I think one of the best examples of intended use is actually from one of the FDA websites. One of the commissioners said, take a jelly bean. If I sell you a jelly bean and I claim it will cure your cancer, that jelly bean is a drug and it's subject to FDA's drug authorities. But if the jelly bean is just intended to be a snack, it's not marketed with any drug claims, there's no other evidence that it's intended for drug use, then it's not a drug. So in our parlance, it's a supplement. And we have to be very careful that we don't call it an animal dietary supplement. Next slide, please. So this is probably the question of the hour. What can veterinarians do with regard to hemp-based products? And the short answer is yes, we can do all of those things. But I want to focus on the word that I highlighted in red, which reminds me to point out that we prescribe FDA-approved drugs. We recommend non-FDA approved products. And that's the same as it is in the human world. Physicians in California do not pull out their prescription pad, write RX cannabis XYZ with a SIG to take 2 tablets and have the owner take it to the CVS or the Rite Aid pharmacy and pick up their cannabis product. That's not the way the availability of the product is, as we all know, and it probably will remain that way for the foreseeable future. So recommend hemp-based products is legal. Next slide, please. I think in the context of the topic, it probably is on all of our minds at times, our concern about what we can do legally. And so I wanted to make a couple of notes about what a board complaint involves. And you may or may not recognize the word standing. It's what the lawyers say is the right of one party to challenge the conduct of another party in court. And it isn't required to file a veterinary medical board complaint. Unlike in a lawsuit, if your house burned down or your animal was injured, you would have standing to file a lawsuit. But that's not the case with a complaint. Anybody can file a complaint. And that makes it challenging because you don't have to be the owner of the pet. You don't even have to know the veterinarian. Second important point is the resolution of a complaint takes a long time. In California, I'm not familiar with the details of other states, but I can tell you that we have more than 3,500 pending complaints in this state. The average cycle time is about 1 to 2 years, and many take more than that. So probably, if there's one take-home message above all others that I could drill down on, it's this next point. The very first thing you do, should you be unlucky enough to get a board complaint, is to contact your malpractice carrier. For many of you, it's probably PLIT, but VISC, Safehold, Hanover, there are many companies that insure veterinarians, and they should be your first call. And before you go to bed tonight, I want you to check your carrier's policy and make sure you have licensed defense, because a board complaint is not, and the costs associated with it, is not covered by your malpractice insurance. That requires a separate rider. It's not very expensive, and it covers, I think mine is $25,000, which we'd like to think is sufficient. But if you have a complicated complaint and it goes on for years, lawyers' fees eat that up in short order. So next slide, please. These are a list of items which I think are important personally, professionally. The first one we've all heard of. If it isn't written down, it didn't happen. This is literally and figuratively true and what the Veterinary Medical Board operates under. So it will behoove us to spend 5 more minutes, and it's usually more than that, as we all know, but the more complete your medical record is, the better chance you have of defending a complaint. And I thought it might be helpful before we jump into the Q&A if I just provide perhaps a possible complaint scenario. Let's say a veterinarian discusses CBD oil for a dog and diarrhea develops. Complaint is filed, and as a practical matter, you could substitute canned pumpkin for the CBD oil and the complaint could still be filed. If the veterinarian represented that CBD oil as a drug, meaning it's going to cure your inflammatory bowel disease or whatever, the VMB could pursue a discipline for violation of an FD&C Act. Whether they prevail is a very different question, hearkening back to the medical records and if and what was written down. So in summary, I'd like to just reiterate 3 main themes. Federal and state laws are not in sync. There are huge differences between states, and hemp is legal with the caveats that we've discussed. And with that, I'd like to turn it over to all 3 of us and the moderators so we can answer some of the Q&A that may have come up.
We don't have any open questions now, but if anyone has any burning questions, feel free to put them in the Q&A box. And then if you sleep at night and wake up and realize you have more questions, obviously feel free to post them on the board, and we'll respond to you as well. That's one of the best ways.
There were 2 questions about inquiring what we can recommend in California, and I apologize, I didn't mean to be cryptic in the Q&A before I started, but I wanted to, knowing that we were going to cover those. And some of the questions may even be better addressed on the message board. So as you know, it'll be open for another, I think, 10 days until September 11th. So we'll be checking those regularly and make sure we get any questions that you have answered.
Yes, and this is a unique scenario where we wanted to save some time for you guys to ask some questions, because we know many of you may not be from California, and like Dr. Pollard alluded to, that some of his stuff was based on California stuff. But if you have other questions from other states, please feel free to use this time or the message boards, as your instructor said. We have a question about the test. If you are taking this course for CE credit, you do have to take the end of course test. It is now posted in your course library, along with many of the other references that your instructors mentioned tonight.
It looks like, Dr. Pollard, there was a question for you, the best strategy with the Vet Med board. Do you want to, I can read the question if you want to answer it out loud, or?
Yeah, that'll probably be more efficient. I've got the question here. So the best strategy with Vet Med board, document any tests declined and document, or actually have owner sign an AMA. I'm going to tell you that I don't generally do AMAs, and I've done probably 20 years of ER medicine, and I'll bet you in early years I've done no more than a handful. And the reason is they aren't going to hold up in any hearing if push comes to shove. The lawyer is going to say that the client does not have capacity. They are not able to understand what you understand on a medical level. So you can use it as is sadly, I think, used as something of a cudgel. I don't mean to call it a threat, but I've seen that done to kind of encourage people, if you will, to do whatever it is you do. But my point is, I wouldn't depend on an AMA. So with regard to the record, I think in California, and I don't know if this is where this Dr. Brandwain is, but in California, and I think this will apply to other states, you want to document what you discussed and hopefully a month from now, what you recommended. And if a problem happens down the road, whatever you have written there is where the board is going to start. The board will also give you opportunity to provide a, let's call it a narrative. And maybe I will just give you a little more detail about California. If a complaint is filed at the Veterinary Medical Board, it's usually online. The board is mandated to process, as they call it, the complaint in 10 days, and they usually do. Process the complaint means a state worker, not a veterinarian, not even an RVT usually, will collect the complaint, will send an acknowledgement to the client, if that's who filed it, will send a request to the veterinarian for the appropriate pertinent records. That happens within 10 days. The veterinarian has 14 days from receipt of that request to reply. And so usually you call up your insurance carrier, they may get back to you the day after anyway, so the clock starts ticking right then. Don't wait, don't delay. You don't have to do anything except make that call. And then from then on, you follow their lead. So that's a long-winded way of saying simply document whatever you feel was pertinent with regard to the discussion that you had with the client.
Great. And then could you answer this for Eileen as well while you're on the topic of legal? She asks, how do you word the recommendation so it's not construed as a drug?
Excellent question. So I'm looking at a bottle of nature-made D3 1000 international units. It says on the label, supports immune health, supports bone, teeth, and muscle health. And because it's a human product, it says legally dietary supplement. So none of those statements are therapeutic claims. And it sounds like semantics, and on one level it certainly is. But the general term supplement is accepted. And in fact, because there aren't very many oversight organizations, the one that comes to mind is NASC, National Association of Supplement Council. That, like on this product, the human product says USP. USP can be on veterinary products too. So as long as you don't claim that it will cure a disease, diagnose a syndrome, you can discuss, and like I said, hopefully in a month, recommend. And I think I'd like Dr. Hazzah to weigh in on this because this is part of her day-to-day also.
Okay, so could you just, I was just responding to some other question, and I know I'm a woman and can multitask, but not as well as I thought I could. So you just have to,
Oh my.
so you just have to, just ask the question. So I
yeah,
know.
I'm sorry. So the question was, and I just lost it. Hold on. The question was,
I think it was, what do you write in a medical record so as not to make a drug claim?
there you go.
Oh yeah. Yeah, no, Dr. Pollard's right. It's the story of my life with Green Isle. This is what I talk to people about. So I use the word education all the time. I'm educating the owners on the potential benefits and the potential risks. I reviewed multiple publications on so it's not what I'm saying is going to happen, it's what's been published. So giving it with food is based off of published evidence. I also it's not illegal for me to share my experience, but I'm not making, and I will literally write this sometimes, I am not making a formal recommendation. I am just educating, and I will even use, this is what I borrowed from a good friend of mine, this term harm reduction education. I've even used that terminology before, which is the owner is terrified to go and pick up a product from a dispensary. They don't know if they're going to hurt their pet, or they've already bought something and they don't know how to do it because they are afraid they're going to make their pet sick. Therefore, I am here to provide a harm reduction education as well as the potential benefits. There's no promises that are made. And with my service, I also have like some consent forms that they sign and all of that. But at the end of the day, I think Dr. Pollard has taught me well enough to know that, like, I write what I talk about in the medical record, and I make sure that I'm not making any formal recommendations. I'm not making any, go buy this because it's going to do that. I just keep using the word education and reviewing the literature. So I'm using terms, and then again, the harm reduction education seems to be a good term to use occasionally as well. I hope that is helpful. And then Heidi asked, I'm still overwhelmed. Is there any other beginning advice? And girl, like, this is a big subject. I mean, this has been years and years of learning, so you're not alone in being overwhelmed. When I have to do anything legal, I have to ask Dr. Richter and Dr. Pollard, because it's like overwhelming for me, just the legal aspect of it. So it's all overwhelming because we talked about so many different subjects. So we do have, you've seen our logo on there. It's called Veterinary Cannabis Society. It's the first US-based nonprofit that's really dedicated to educating veterinarians and pet parents and companies, the industry, on cannabis for pets. So we have podcasts and videos and all this kind of fun stuff. And hopefully we'll be able to put presentations like this and others on there for folks to review again. And we do coffee chats where we discuss, I think the last coffee chat was a legal conversation, and the first one was, medical application. And it wasn't just what I talked about. Other people brought in some other stuff. I think the upcoming coffee chat is going to be us talking about cultivation. And we have actually some vets that do some cultivation talking as well. So feel free, you can go to vcs.pet. And it's, again, a nonprofit. We're just here to educate as many veterinarians and pet parents and industry as possible, so everyone we can all do what we can to keep our patients and pets safe. So that is that.
Valerie asked, what about pain? Discussing pain control. Can that be construed as a drug use rather than a supplement?
Well, so, do you want me to answer?
You go first, please, Dr.
Okay.
Hazzah.
I was just gonna say one thing, and then you'll probably answer it even more detailed. I was just gonna say, I don't even really use control unless it comes from a publication. I just say like support. I use the word support. So we're
Support is the right word.
Yeah. Yeah.
Supports a normal inflammatory response.
Yeah.
It's the truth. Imagine if all of a sudden you could turn back the clock and NSAIDs came on the scene, and we all had to learn about COX and LOX and pathways, and it would be, like the previous questioner mentioned, overwhelming. And it's kind of the new world, and it's even stranger because if you think about it, probably more clients have it on their radar. I won't say know more about cannabis than veterinarians, but I think because of the history and the nature of the product, veterinarians are a cautious group, and I think we've been really made fearful by our veterinary medical boards. So now legislation is starting to catch up with practice, and it's going to be a continual slow process, it would appear.
Okay. And
One
then
question about cancer there, Dr. Hazzah.
Who should answer that?
One more question on using this CBD with cancer. I have found in my literature search that some people have been using 0.5 mg per kg BID. Would I start with this or do the 0.3 mg per kg you mentioned and then slowly increase? Part two of the question, how do I know when to increase the dose?
Trina? Did we lose her?
She looks like she's in the room, but maybe her microphone.
All right. Well, I'll start until
Sure.
Trina finds her voice. So the reality is that CBD is incredibly safe and has really minimal side effects. So honestly, whether you start at 0.3 or 0.5 mg per kg BID is probably not really a sort of a mission critical decision. I think you could quite honestly do either one of them and be fine. As far as how do you know when to increase, from a cancer perspective, and I'd be interested myself to hear what Trina has to say about this, but, for me, I usually like to try and get animals that, if it's actually cancer that we're working with, to try and get them on a relatively high dose. So, for CBD, maybe every 5 to 7 days, I'll increase the dose a little bit, a little bit being maybe like, I don't know, 20% or so, so we can get them up to what I would consider a reasonable dose. There's, needless to say, there are no clinical trials as far as CBD and cancer in animals. But if we look at the clinical trials for osteoarthritis and seizures, you're looking at doses in the neighborhood of 2 or 2.5 milligrams per kilogram BID. Were shown to be both effective and safe in those studies. So I think you're well within safety to go that high. So that would be the advice I would have if it's really about CBD specifically. Needless to say, if there's some THC involved, you need to be a bit more careful from a dosing perspective. But whether you start at 0.3 or 0.5 mg per kg BID, I don't know that it's that important.
I think Dr. Hazzah might be back.
I'm
Trina?
back.
Oh, she's back. Did I make a fool of myself?
No, you're beautiful. But it was
Thank you.
phenomenal. It was great. Yeah. So Dr. Richter is totally correct. There is no magic dose for cancer, number one. And where you start probably doesn't matter with CBD as much because it's fairly well tolerated. In my experience, I just do not stop titrating until there's either a remission that's been durable or their side effect. And so I think it depends on what your goal is. If it's anti-tumor, then just keep titrating until there's a problem. If it's palliation, then you titrate until you get the response you're looking for: reduced pain, improved appetite, reduced nausea, whatever it may be, improved quality of life factors like a little bit more euphoric and more comfortable, whatever it may be, and then maintain it there. Because remember, if you go too far beyond that, you may go beyond that optimal dose and get just negative effects with no positive effects anymore. So I would say, at the end of the day, I just keep going. There's some evidence, and I waver between this continue to titrate indefinitely versus, if it doesn't work, versus switching product. What I mean by that is there's some evidence that, and it's not a lot, but there's some evidence out of Israel that looked at, it's not necessarily the amount of cannabinoid, it's the exposure to any amount of the right cannabinoid combination that does it, cannabinoid terpene combination or flavonoid combination, whatever it may be. I think it's probably, you got to get enough into them, but I don't know if you have to overwhelm the system necessarily if it's going to have anti-tumor effect. I have seen a tumor go away at 1 milligram of CBD and a 1 milligram of THC, and literally the dog had progressive disease, on a targeted therapy, started nothing other than cannabis at that 1-to-1 ratio, and the tumor went away 90%. And that's a teeny dose. It was a small dog, maybe, 20 pounds or 30, something like that. Small, 20 pounds, I think. So that kind of supports what the Israeli study showed. But then, there's some folks here, in the human space, a lot of the folks, the physicians, are just giving humongous doses of cannabinoids, and they're seeing effect that way. So I would say it doesn't matter what you start with CBD wise. If you want to get THC up for whatever reason, it's the right tumor to use THC. You're looking for more what they call, CB1 agonist, as Dr. Richter talked about. CB1 is the receptor that is more in the central nervous system that will help affect mood and appetite. I mean, CBD is going to not do anything for the appetite. Then you may need to get your THC up higher. And so how do you know when to increase the doses? You set a titration schedule based off of many of the factors we talked about and the parameters I talked about today. And you say, okay, I'm going to go up every 7 days. If you notice any side effects, then you just reduce the dose back to the one that was tolerated, wait another week or 2 or 3, and then try to titrate it again. And if you find a maximum tolerated dose, that's the dose you stay on. And incorporating other cannabinoids. If you can't get any more of one formulation, and sometimes just add in another formulation that has a different profile of cannabinoids and terpenes, and that allows for a little bit more diversity. It allows me to push the dose without using just the one formulation, because sometimes it's not just the THC or the CBD, right? It could be the myrcene, which is that terpene in the product that is potentiating the effects of THC, or causing somnolence or lethargy or whatever on its own, and just switching the formulation could work. So hopefully that was helpful for you. Feel free, to ask additional questions during the on the board as well, if you come up with more on that topic.
Dr. Hazzah, would you add to what I mentioned to Heidi Castle? She asked, how do you discuss in a time-efficient way? Do you use handouts with product names like I do for joint supplements?
Yeah, good question. I think what you do, I'm trying to think, obviously, I think you have to find, so I listed some of the reputable companies. We can't really make a comment on which is the best or make a specific recommendation, but there are certainly some reputable companies out there. What I might do is start with some of the information you learned tonight, and whatever else you read on your own. Feel free to kind of peruse some of those companies and call the companies if you have time. I mean, the problem is veterinarians, I mean, there's just no time. You're inundated with everything. So what I would do is maybe ask around your colleagues. Feel free to, you can reach me at greenisle.org and ask me, if you had a problem with a company or whatever, maybe start to find some of the companies that you like, right? Like just like you do for an NSAID. Like I really don't like Deramax. Why? Because I had a bad case. So now I just like use Medicam, right? And I'm a Piroxicam girl because I'm an oncologist, but most people don't like Piroxicam because it's non-selective, right? You figure out kind of what are your comfortable companies and products, and then you essentially can make a list of those. You can also in California, if you're in California, Heidi, obviously you can carry products that you like and sell those directly to folks. And then you can probably get feedback from owners that way. So I think just kind of going with what seems like reputable and transparent and comfortable companies. And again, feel free to reach out to us. We'll support you in trying to find some companies. VCS, we are product neutral, but we certainly have open conversations about, the importance of high quality products and all of that stuff. So feel free to, join and ask us questions there as well. I don't know, Gary, can you think of anything else that might help Heidi?
I mean, I don't think that there's an easy answer to that, especially because, in veterinary medicine right now, we're all so rushed into doing everything. So yeah, I mean, no, I'm sorry. I don't have a really elegant solution to that other than, yeah, I mean, if you're comfortable with handouts as far as brands, that's certainly something you can do. Have something that you can email to people. That's an option as well. But yeah, I mean, that's a tough situation for just about everything we do right now, because who has time to really have the conversation that we want to have?
And the other thing I was going to say is, on VCS, we have a directory of practitioners, and those are some of the folks that are comfortable having these long conversations with clients. So similar to how you, refer a patient for onco or for neuro or whatever it may be, you can always, if you just are like this, how we all know, like I remember in onco when someone had major derm questions and I was like, it was beyond what I knew, which was very little anyway. I would just say, you know what, maybe you should see a dermatologist, because I don't know if I'm comfortable answering the questions to the level that you want. So feel free to, send clients, to practitioners that are a little bit more comfortable too, or just kind of try the products yourself with some of your patients or your own pets and see which ones feel right to you.
There's a question, is there a major difference in onset time between tinctures and edibles?
Well, if the tincture is absorbed submucosally, so let's say you got a tincture that sits in the mucous membrane for a little bit longer, then absolutely, it will be much quicker. It will go right to the bloodstream. So you'll pass, you'll avoid first pass. Granted, most of these products that are tinctures, oil-based tinctures, are oftentimes swallowed afterwards, right? So you kind of get both, and that's if it sits in the mouth long enough. Otherwise, a liquid, it depends on what else is in the formulation. If it's a capsule, I'd be more worried that would take longer because it has to break down, versus if it's in some sort of treat that's really dissolvable pretty easily, then it will probably be similar to a tincture that you took with some food.
And then one other cancer question, has there been a study on whether some of the anti-neoplastic effect is caused by the cannabinoid, increasing levels of chemotherapeutics, or targeted treatment drugs that are metabolized by the liver?
Is there a study if the anti-neoplastic effects are from which one they're from? Is that what it is?
It says, has there been a study on whether some of the anti-neoplastic effect is caused by the cannabinoid increasing the level of the drug or targeted treatment drugs?
Yeah, okay, great question. To my knowledge, there's not an actual PK study looking at the level of I don't think it would be targeted. I don't think it would affect targeted that way, but maybe because some of the P450 substrates are chemo drugs. There's not been a study to my knowledge looking at that right now. The studies that are out that are cancer veterinary in vitro studies have looked at how CBD, and it was there's just CBD and CBDA. So the CBDA didn't really do a ton, but the CBD actually worked synergistically and additively with shot-based chemo, and then a separate study looked at it working with vincristine in a synergistic fashion. And so that to me seemed, but they didn't test levels to my knowledge. It just seemed like they worked better when they were given together. They were able to kill more cancer cells, even if they were given at lower doses than them by themselves, which is synergy, right? Some of them I think were additive, where 1 + 1 = 2. So the dose of vincristine and the dose of CBD was able to get the effect that you would expect for both of them together. But they didn't look at actual levels of the drug or PK level of the cannabinoid itself. One of the studies showed that, interestingly, that the CBD was antagonistic with doxorubicin for when they looked at a variety of 3 different cancer cell lines. It was like 1 B-cell lymphoma, 3 osteosarcomas, and 1 mammary gland tumor. They found that there was an antagonistic effect if CBD was given and doxorubicin were both given at subtherapeutic doses, but when they were given at therapeutic doses, there was synergy. And then there was a TCC paper, all in vitro again, that looked at synergy between CBD and mitoxantrone and vinblastine, but actually antagonistic regardless of the dose, I think. I don't know if they looked at sub or not. I think they were just both therapeutic with carboplatin. So antagonistic with carboplatin and no effect necessarily positive or negative when given with piroxicam. So that was a very long-winded answer. But I don't know if any other study has looked at drug levels per se. They just, usually it's just in the Petri dish, right? Because it's not, we have 0 clinical trials looking at cannabis, any cannabinoid, and cancer in veterinary patients, 0. It's all in vitro, and there's like a total of 3 published and 1 unpublished at this time.
Looks like there's just one other question in the queue. Again, cancer. Again, I apologize if I missed it, but do we have in our notes a list of the various cancers and the combinations that work best for each?
God, no, that's like, yeah, you know what? I'm trying to think. Where can you get that information? I mean, I just do lit searches all the time to kind of see that. There is a paper. It doesn't exist. I mean, with what I know exactly what you're looking for, and it would make a lot of sense to have something like that, but there's still so much research that needs to be done, right? So there is a textbook that was published, God, I can't even pull it up on my screen. Hold on here, let me tell you the name of the textbook. And you can at least read some of what I did in this textbook. Was I just wrote all of the published, and this was like a few years ago, so it's not even totally up to date, but I broke down all the different literature for every cancer, and if there was clinical research or if it was just preclinical in vitro, and almost all of them is preclinical in vitro. There's very, very, very few. So there's a book called Cannabis Therapy in Veterinary Medicine that was published a few years ago that will have some information. And then just do a lit search. There's a few really good kind of cancer cannabis articles that break down different cancers as well, but you're going to have to pick apart all of them and kind of figure out what makes sense through mechanism. And I think that as we start to have clinical trials on cancer patients, because what works in vitro doesn't necessarily mean it's going to work in vivo. That's the problem, right? And so you have some information to guide you, but it's not the same as clinical trials in veterinary cancer patients. So we need to have those to really help guide you.
Looks like all the questions have been answered. I want to just throw out there the recommendation to go to the library. The moderator did a bang-up job of populating and organizing the library into folders that I think are going to be helpful to participants. So again, ask any questions you have on the message board. And Dr. Richter, Dr. Hazzah, any other thoughts?
Other than to say thank you to everybody for participating, and we will look for your questions on the message board, and we hope you find a use for cannabis in your practice.
Thank you, everybody. Thank you. Have a wonderful night.
Good night, everyone.
Bye all.
All right, everyone. Thank you so much to our instructors this evening. Again, if you are taking this course for credit, your end of course test is now posted in your library, which hopefully you'll swing by and look at all the references they have there. There's also a course evaluation. We love hearing your feedback. If you enjoyed this class and you want more like them, please let us know. And we will see you on the message boards. Thank you to our instructors and have a good morning, good afternoon, good evening, wherever you are. Thank you, guys.
Thanks, everyone.
Thank you.